Good morning, everyone. This presentation was made by the University of Algarve by the Medical Imaging Department on behalf of a student who could not be here. Our main objectives are to estimate the dose that patients receive beyond the anatomical limits needed for the diagnosis, because we always get a little more image, usually. Then to recommend the greater rigor in the examination planning, if needed, to assess the extent of extra imaging beyond the prescribed anatomical limits for chest, and to determine the associated extra patient and organ dose estimates that we acquire. We all know the number of CT examinations is increasing, and therefore dose as well. Patients undergoing CT examinations may be exposed to high doses because such simple methods are overlooked, and with the introduction of faster and faster devices with higher tube load performance, there is a tendency to extend the imaging area beyond the area of interest, with the consequence of associated extra dose. Our literature review, we saw that about 98% of chest, abdominal or pelvis CT examinations, the image volume is larger than the actual volume of interest, with an associated extra dose. Okay, so our study is descriptive, retrospective, because we analyzed previous exams, and quantitative, presenting an exploratory nature. I would like to show this image. This is the software we used. You can find this software free on the internet. It's very good to analyze the amount of volume scanned and to help estimate doses. This is an example of extra Z coverage in an adult male. You can choose female and male if you want. On the right, the coronal view of the patient used to determine the upper and lower boundaries you have here in yellow and red. In this patient, the extra length of the CT data acquisition was quantified as to 1.9 centimeters on the top and 5.4 on the bottom, corresponding to a total extra imaging length of 7.3 centimeters. So we had 90 consecutive routine chest examinations performed at a single institution. Each CT protocol contained about as many male as female patients, 47 males and 53 females that underwent the exams. The patients were all adults with an age range of 35 to 79, average 59 years. And we tried to keep the body weight and size as close as possible in order that they're all similar in terms of dose, because what we wanted to know was the extra volume acquired. The CT equipment and parameters are here. We used for every examination a Siemens Sumatomy Motion 16. This is our standard protocol. It's a very basic protocol used for chest routine. This is our equipment technical specifications, very standard. So for routine chest CT, superior and inferior margins, as defined at our department, were the lung apices and the costodiaphragmatic sinus, respectively, to accommodate for changes in imaging length due to patient's respiration. 1 centimeter above and below these anatomical margins were considered still within the prescribed anatomical regions. This is because we have to account for patient breathing. When we acquire the topogram, for example, patients breathe in, but when we do the exam, they do not exactly breathe the same way. It has some variation. So we need to give a margin of error to estimate what we acquire more. This is the software we use. It's not very big, the images, but this is just a demonstration. You can choose the patient and the area that you study. We also then analyzed how many additional images we acquired. The avoidable DLP in images acquired beyond the prescribed anatomical limits, the avoidable DLP in milligram per second was calculated. Then we sum this up above the pulmonary axis plus the lower DLP below the adrenal glands. And then we performed a total of avoidable DLP. We then moved on to calculate organ effective dose, and this is our standard deviation and averages. So basically, for a chest exam, this is for every organ, this is the values we obtained. And these are the extra images above and below that we acquire. So it's not that many images. Above we have 3.2 and below we have 4.4. And this is our average DLP milligray by centimeter. So we can consider it's not very high, but we still have to take this into account. We have an extra DLP of 88.9 milligray per second. This is the average effective dose in the organs in millisievert. Of course, we see that the closer the organs are to the limit of the extra images acquired received higher dose, but this is to be expected. Regarding the unnecessary amount of dose to the patient, in average, the patient receives 1.11 millisieverts of effective dose and 88.96 milligray per centimeter of avoidable DLP. Regarding the average of additional image, there's an excessive amount below the adrenal glands. And so I can say that there is improvement for technical parameters of acquisition in the chest CT exams in order to reduce patient dose. Beyond the anatomical limits during routine chest exams and abdominal CT results is higher organ and effective doses, and maybe some continuous training and warning for some radiographers not to acquire excessive images. Both physicians and radiographers must be kept aware of additional dose associated with extra imaging. So, thank you.